morning. Today's lecture will be on platelet morphology and platelet indices. And I'm Dr. Joy Augustine, Professor of Pathology. Now, this is how the lecture is going to go. I'll be saying a few things about the platelets, the basics. Then we will talk about the hereditary functional disorders. And then we will look at the morphology of the platelets in qualitative disorders, that is the functional disorders, and then the quantitative disorders. Now, the second part of the lecture will be based on platelet indices and their relevance in clinical medicine. So, platelets are basically the smallest formed elements in the blood. As you can see, they're pretty small. Their size is approximately 1.5 to 3 microns in diameter. Usually, it's 2 or 3 microns maximum. And basically, the characterization of platelets would require a combination of morphology and also the count. So this is important. So here the analyzer or the cell count also comes into the picture. And we'll go on to see what is the most important thing. Examination of the peripheral blood smear is important in cases of unexplained thrombocytopenia or thrombocytosis. Now, it's a debatable question regarding mandatory examination of the blood smear. However, certain conditions does require the examination of the peripheral smear, because sometimes the analyzer itself would give you a lot of information regarding the nature of the platelets, the count, etc. But to make it very, very accurate and useful, blood smear should be examined in the smear, and this may provide a lot of information regarding the underlying cause of the low or the enhanced platelet count. Now, one point I mentioned at the start itself is that small platelets is generally suggestive of a defect in the platelet production. And whereas when you see larger platelets, they are more likely to be associated with enhanced platelet turnover, or sometimes the rare hereditary thrombocytopenias. Okay, now we'll go on to the functional and acquired conditions. Now, this is basically the normal platelet. The normal platelet has got a central darker area and a peripheral lighter area, which is constituted by the microtubules, and this is called the cytoplasm. And the central part generally contains the granules, and it will contain the secretory apparatus of the platelet. Now, an unstimulated platelet, resting platelet, would be fairly round in shape, while on the other hand, an activated platelet would have lots of thin seropodia coming out. And this is important in actually attaching itself to the subendothelium and also to each other. Now, if you look at the clump here, this is how the clump would really look like under the scanning electron microscope. Now, there are three main groups of hereditary functional disorders. Defects of adhesion, the best example would be Bernard-Solier syndrome, defects of aggregation, Glanzmann's thrombocytopenia, and disorders of platelet secretion or the release action, which is known as the storage pool disorder. This is one of the largest, it's a large group of disorders, and a good number of them are associated with other systemic manifestations and syndromes, which is why most of them are named as syndrome. Of course, one more is important, that is the Viscott-Addison syndrome, which I have not mentioned here. It will come into the table which you see next. Now, one other point, very important to remember, is that uremia is one cause of an acquired platelet dysfunction and can actually masquerade as any one of these disorders. So, if a platelet count is low or platelet count is normal, but apparently the patient seems to have platelet defect, bleeding or hemostatic problems, check the renal function. This is very, very important. Now, this is the large list of the storage pool disorders, some of which are not so uncommon, and you may come to see celiac acid syndrome is not so uncommon. We do get to see them maybe once a year. Biscott-Aldrich syndrome is quite rare. Hermansky-Putlag syndrome is quite rare. And this is associated with lung manifestations. Celiac gastric syndrome is associated with albinism, infections, repeated infections, and is basically a lysosomal defect. Platelet defect is a part of it. Biscott-Aldrich syndrome is another condition which one might come across, and this is also associated with a T-cell immunodeficient state. Now, the secretory mechanisms may be deficient or defective in a large number of conditions. Cyclooxygenase deficiency, thromboxane deficiency, these may lead to either to increased bleeding or increased coagulability of blood. Now we just look at one or two of them. This is Bernard-Solier syndrome, is a defective addition of platelets to the subendothelial matrix. Now this is because of a deficiency of this complex 1B9, and this is a receptor for the von Willebrand's factor. For this reason, von Willebrand's disease and Bernard-Solier may have overlapping type of symptoms. Of course, there is another condition which is slightly different, which is known as the platelet type of von Willebrand's disease. That's a totally different condition altogether. Now, in this condition, usually the platelet count is low with an elevated mean platelet volume, which simply means that though the platelet count is low, you may find large number of giant platelets or very large platelets. And this is a condition which can produce significant bleeding. Now, the other condition which we may come across is Glanzmann's thrombocytopenia. Now, this is a defect of platelet aggregation. In fact, it is a defect of aggregation so much so that we have almost every other agonist which can be put forward. And because of this, the platelets do not get activated. And for that reason, they are energy deficient. And they are low energy platelets, which is why the term asthenia was actually given. Asthenia means weak platelets. And this function, this is because of a lack of 2B3A. It's an integrin, and it participates in the bridge formation between the platelets and the fibrin and fibrinogen. And this may often present with a very serious bleeding tendency. Incidentally, this is an autosomal recessive disease, and there is an invariable history, a consanguinity history can be generated if you ask questions. And the other point to remember is that the CBC in individuals with Glanzmann's thrombocytopenia is usually normal, with a normal platelet morphology and a normal count, except for one thing. The clumps that you see is seen in a normal blood smear. This is absent in Glanzmann's thrombocytopenia. So platelet aggregation is totally absent, and this is a good clue for diagnosis. If at all you suspect this, take a direct blood smear, capillary blood smear, and check it out, and you will find that the platelets are seen singly. Now, this is a list of the aggregation function, of which one of the two things which I would like to point out is this Glanzmann's thrombocytopenia. There will be decreased or absent aggregation to all ADP, epinephrine, collagen, and histiocysteine. Rarely, of course, it can be normal with histiocysteine, but it is usually abnormal. And Bernard-Solier syndrome can be actually absent histiocysteine aggregation. Now, this is the same thing. This happens also in von Willebrand's disease. Now, the other point to remember is that generally when you do an aggregation test, you have two waves of aggregation, the primary wave and the secondary wave. Now, in storage pool deficiency, the secondary wave is absent. Now, this is very, very significant because the primary wave will look quite okay, and the platelets in the peripheral blood may look almost normal and they may produce aggregates and clumps. However, the second wave is absent, and this is because the first wave is due to the initial interaction and exposure to the agonists, while the secondary is due to the secretion of the platelets itself. And when they are absent, the second wave of aggregation is absent. So this is the point that you should remember. Now, the other thing is when the patient is on aspirin, you can get a similar type of absent second wave for ADP and epinephrine. Now, this is a good thing to remember. And the aggregation to collagen is almost completely absent. Now, what are the morphological abnormalities of platelets? Now, there are three. Can be granulation abnormalities, can be the shape and the platelet size. Shape is not so common in the sense that platelets can assume oval shape, thread-like appearance, etc., but they may not be very specific. And this platelet morphology is extremely important in diagnosis of myeloproliferative and myelodysplastic syndromes. Now, what are the causes of hypogranular or agranular platelets? The most important, of course, is the gray platelet syndrome. And very often, all these hypogranular platelets belong to the group of storage pool disorders. And Viscott-Aldrich syndrome is an X-linked disease. It has, in addition to being agranular platelets, the platelets are generally very, very, very small. So this point also may be noted. Now, there are some acquired reasons why the platelets can be agranular or hypogranular. In vitro degranulation, a difficult venipuncture. Now, when there's a difficult venipuncture, what happens? Platelets tend to aggregate. And when the platelets, when there's a difficult venipuncture, you find that the platelets get activated. And when the platelets get activated, you find that the central dark area which contains the granules, they degranulate. And this is one of the reasons why in a difficult venipuncture, you get pale platelets or agranular platelets. Now, in vivo degranulation is classification, as you can well understand. In disseminated intravascular coagulation, you find that all the platelets are basically, whatever platelets you see are activated, and you find that they degranulate as a physiological phenomenon. And finally, you have got this condition. You can include leukemia also in this, acute leukemia. Myelodysplasia and myeloproliferative neoplasms, generally, they have a tendency to have agranular platelets, normal platelets, and hypergranular platelets. So this is one of the things that you can see in myelodysplasia and any other condition, rarely in megaloblastic anemias. So you will find agranular platelets, granular platelets, and platelets which appear to be hypergranular. And this, in combination with fairly significant degree of anisocytosis of platelets, will point to the real diagnosis. So by just looking at the platelets in the blood smear, if you suspect one such condition, you might be able to confirm it as such. Now, these are inherited thrombocytopenias with large platelets. Of course, Bernard-Soley syndrome is one of them. Then you have the MYH9 related disease. Mayhagen belongs to this condition. Then you have the gray platelet syndrome. And of course, the one condition which we should all be conscious of is the macrothrombocytopenia of North India. I'll just delve into this a bit. Asymptomatic constitutional macrothrombocytopenia is also known as Harris platelet syndrome. And this is well documented in the northeastern India, primarily in Bengal. Now, the problem is that we have a lot of migrants from Bengal, from north and from eastern India. And if we are not conscious of this, what happens is that the condition will be recognized as pathological and the patients will be subject to all types of investigations and management. So we have to be conscious of the fact that this asymptomatic constitutional macrothrombocytopenia, also known as platelet syndrome, presently called as Bengal macrothrombocytopenia, is a condition which is relatively asymptomatic. For that reason, an incidental finding of giant platelets and thrombocytopenia did not raise any alarm bells. Now, the other condition where you have giant platelets is the May-Higgin anomaly, Epstein syndrome, Fechner syndrome, Sebastian syndrome. They are all belonging to the same group of this MYH9 related disorder. And this is the one which has got these syndromic manifestations, where you find that patients have neutrophils with Dolly bodies and giant platelets in circulation. Now, the other conditions are associated with renal problems, deafness, ocular problems, etc., which actually differentiate it from the May-Higgin anomaly. Now, what are the acquired causes of? There are a large number of acquired causes for large platelets. The most important being storage artifacts. Now, if the platelets are stored for a long period of time, you find that the platelets get swollen up and it becomes large. Now, this can be sometimes recognized by the very indistinct, loose, sponge-like appearance of the platelet. However, you can't be sure about it, but you'll have to check out with whether there was any prolonged storage. Immune thrombocytopenic purpura, thrombotic microangiopathies, DIC, infections like dengue, they all cause large platelets. Then, of course, you have got a group of neoplastic conditions where you have large platelets, and some of these conditions will have thrombocytosis with large and small platelets, which is very classical. And then in post-splenectomy states, you get marked thrombocytosis with marked platelet anisocytosis, and rarely you can get drug-induced, where the cholestyramine is a drug which is given for reducing the cholesterol, and this can actually produce enlarged platelets in the peripheral blood. Now, physiologically, the platelets in neonates can be large, just like there are RBCs which can be large. So we have to be careful about this. Now, what are the inherited thrombocytopenias with small platelets? The most important is Biscott-Aldrich syndrome or the X-linked thrombocytopenia. It is generally the gene abnormality is in the VAS gene, and it's a X-linked disease. Now, this also is one type of inherited thrombocytopenia, but this is autosomal dominant and not associated with T-cell immunodeficiency, which Biscott-Aldrich is associated with T-cell immunodeficiency. The others are very rare conditions. Now, lastly but not the least, acquired causes of small platelets. The key factor to remember is that in the presence of thrombocytopenia, the small platelets plenty is a feature of impaired platelet production in the bone marrow. We have to be sure about this. And one of these may be the cause. You can get it rarely in megaloblastic anemias. Now, this is just a slide to show you the different sizes and shapes. Small platelet, normal platelets, giant platelets, the May-Higgin anomaly with the Dolly body in the neutrophils. Incidentally, this is important to remember that Dolly bodies can be normally seen in neutrophils. And those neutrophils generally will have toxic granulation because they are associated with the infection. However, in May-Higgin anomaly, the Dolly body is seen in neutrophils which do not have toxic granules. And now you have the large platelets, and then you have the gray platelets or the pale platelets. And this is in this condition, the gray platelet syndrome, the platelets tend to be larger. Now, this is another important, it's fairly recent. You can actually make a diagnosis of some platelet disorders by immunofluorescence techniques. You can make a blood smear. You can actually send the blood smear to any reference laboratory where this is being done, and you can get a diagnosis. And this is based on the presence or absence of certain tubular proteins or presence of abnormal cytoskeletal proteins. So, and you can also demonstrate the absence of alpha and delta granules. But if the disease is manifested by impaired signal transduction, it's difficult to identify it on immunofluorescence smear. I'll show you a slide of this. Now, this is a May-Higgin anomaly where you find accumulation of the myosin 2 heavy chain in the neutrophils. And this can be demonstrated by the presence of fluorescence like this. While the normal neutrophil will not have any spotty fluorescent areas. So this is one way of checking out. This is the presence of abnormal proteins. Here you have a tubulin. The protein tubulin is defective or absent, and this is a patient, and this is the normal fluorescent pattern which you can see, and so it's very easy to recognize if the patient has the disease. And this is a little more difficult condition where the FLNA-RT is deficient or defective. So you may find that the fluorescence is irregular or dim, while this is the control where it is normal. Now the same thing applies to this Viscott-Aldrich syndrome where the tubulin protein is abnormal, and you'll find that abnormal distribution of the tubulin protein. This is a normal distribution, circumlinear, because it's seen in the peripheral cytoskeleton of the platelet. Or you can have abnormal shapes like this. So this is the Viscott-Aldrich syndrome. So it can be used to make a diagnosis of inherited thrombocytopenias. Because the conditions are very rare, these tests are maybe done only in one reference center. And the advantage of doing it on the peripheral smear is it can be preserved very easily, unlike a blood sample, which is difficult to transport and preserve. So this is one of the newer technologies in platelet morphology and identification of conditions. Now, normal platelets are agranular. Agranular and hypogranular may be seen in myelodysplastic syndrome. Now, this is the point. Here, this is a slide of a myelodysplastic syndrome where you find normal platelets, pale platelets, giant platelets, normal size platelets, large platelets. So, when you find something like this sort of appearance is characteristic of some form of myelodysplasia or some form of neoplastic proliferation in the bone marrow. So this can occur in myelodysplastic syndrome and also in myeloproliferative neoplasm. Now this is a picture of essential thrombocythemia where you have thrombocytosis with varying sizes, giant platelets to small platelets to tiny platelets. So this sort of anisocytosis of the platelets with thrombocytosis is the hallmark in the peripheral blood of primary essential thrombocythemia and primary myelofibrosis. Now again, giant platelets. This is a condition where you have a myeloproliferative disease, myelodysplasia. This is a patient with Howell-Jolly body in the RBC and a giant platelet, and this is the classical May-Higgin anomaly. Now, this is another picture of hypogranular and normal platelets which can be seen. This is also characteristically seen in myelofibrosis and myelodysplastic syndrome and some forms of AML. Now, when you see this is basically a megakaryocyte fragment. You can identify this by seeing the peripheral blebbing of the cytoplasm, which normally you don't get in a giant platelet. So this is one way of identifying that. And these are two megakaryocyte dwarf megakaryocytes. Now, seeing this in the peripheral smear is generally a feature that you should identify as likely myeloproliferative disorder. Now, this is the inherited gray platelet syndrome, which is just a duplication of the previous. And small platelets. Now, these are very small platelets. Please do remember that impaired platelet production in the bone marrow is the one important cause of acquired small platelets, and especially when it is associated with thrombocytopenia. And in other causes, there are a lot of other causes like iron deficiency anemia, where you get tiny platelets, but they can be identified because of their ancillary findings, which you can see. Now, immunological platelet counting is a reference method endorsed by the International Council for Standardization in Hematology. And how is it done? Actually, it is done by counting the platelets by FITC conjugated monoclonal antibodies. You can see the 41 and 61, and analyzed in a flow cytometer and counted. While it's compared with the RBC count in the same preparation. So, this is the reference method of counting the platelets. This is not generally done, but this is supposedly the most ideal method. Now, what is pseudothrombocytopenia? Pseudothrombocytopenia is the presence of thrombocytopenia by an analyzer, a cell counter. And you can get this sort of thing when there are platelet clumps and fibrin, or when there are macro and giant platelets, or when there is platelet satellites. Now, pseudothrombocytopenia is common. The most common reason for that is sometimes EDTA will produce clumping, and this is not very common, but it's common enough to be worrying. So you'll get very low platelet count, but on the other hand, the smear will actually show platelet clumps. Now, this emphasizes the importance of checking the blood smear for all cases of thrombocytopenia, which is not expected. So when you get an unexpected thrombocytopenia in a symptomless patient, it's important to check the blood smear. Now, there are people who actually say that you can actually pick it out from the histograms, platelet histograms, etc. It is true, but of course the gold standard is actually seeing the platelet counts. Now, sometimes you can get falsely elevated platelet counts because of small circulating particles like erythrocyte fragments, microerythrocyte fragments of leukemic cells, and fragments of lymphoma cells. The fragmented red cells can be actually made out by the analyzer itself, because some of the analyzers do have a validated fragmented red cell flag. So that can be done, that can be recognized. But the others, fragmented cytoplasm of the leukemic cells and lymphoma cells, etc., generally are difficult to pick up. Now, one method of recognizing the EDTA associated pseudothrombocytopenia is to repeat the same test, taking a sample of blood with citrated blood sample will not show the serrated appearance which is seen in the EDTA blood sample, and so you will get a normal count. It can also affect the WBC histogram also. Now, this is picture showing the platelet satellitism. The exact reason for this is not known. The exact reason for this, exact reason for this is not clear. And some individuals possess agglutinating antibodies against, agglutinating. The reasons behind why certain individuals possess agglutinating antibodies is not very clear. But it's not that common. It's basically it's just seen in 1 in 30,000 people. So it's not that much of a serious issue. Now, these are the fragmented red cells which are seen in hereditary pyropoikilocytosis. These are the fragmented cells in hemolytic anemia, cryoglobulinemia, And these are the fragmented cell of the cytoplasm of the lymphoma cells. Now, this is quite common when there is a large cell lymphoma spilling over onto the blood. This is because the cytoplasm of the lymphoma cells is very fragile and they will break up quite easily, and they will be seen as globules like this. And this can be picked up. It's very difficult to pick it up in the smear or in the cell counter. However, with some degree of experience, you can match the color of the cytoplasm of the circulating abnormal cells with the platelets, and that might be a clue. Now, just remember a few things. Diseases which primarily present as thrombocytopenia, microangiopathic hemolytic anemia, DIC. If you suspect that, look for cystocytes. If you look for myelodysplastic syndrome, look for pelteroid cells, blast cells, and of course you can look for the anisocytosis of the platelets, the thrombocytosis, and the anisochromia in the platelets. If you think if thrombocytopenia is likely clinically a leukemia, look for blasts. And don't forget the hairy cells, because this is quite maybe very few. And of course, don't forget infection, particularly falciparum malaria, and of course, typhoid fever. Now, this is just a picture showing the same thing. Vivax, hairy cell leukemia, myelodysplasia, cystocytes in Maha, and acrocytes in myelofibrosis. Now, megakaryocytes in circulation are rarely found in the blood smear. However, several studies have reported megakaryocytes as being present in patients with hematological neoplasms. Several references for this, but I am yet to have not yet seen a megakaryocyte in the peripheral smear so far. Now, megakaryocyte bare nuclei may be seen in the peripheral blood. These are all pictures from the internet. You can get megakaryocyte fragments. As you can see, this fragment has got platelets budding from it. These are megakaryoblast. This is actually a megakaryblastic leukemia. This is a megakaryoblast with a large fragment of megakaryocyte with these blebs coming out associated with hypergranular platelets. So most likely this must be a chronic myeloproliferative disorder transforming to an acute leukemia. So that's how we put things together and come to a diagnosis. Of course, this is a very subjective science, but however, you can do it most of the time. Now, reporting platelet morphology in the peripheral blood smear, giant platelets, if present, should be graded as few, that is less than 10%, plus 2 if it is 11 to 20, and if it is plus 3, it is greater than 20%. And it is mentioned that you have to mention the presence or absence of hypogranular platelets, megakaryocytes, megakaryblasts, if you see in the peripheral blood smear. Hypogranular platelets frequently you can see. The others are not generally forthcoming. Now, occasional observation of giant platelets in healthy subjects should not be reported. Now, this is a point which has been recently put forward because of a large number of conditions which actually have giant platelets, and they are known as constitutional macrothrombocytopenias or macrothrombocytosis. And it has been described in the Mediterranean and also in the Indian subcontinent. Now, communications of small megakaryocytes, this is of course not very relevant here. Presence of microplatelets should be reported only with thrombocytopenia. This is very important to remember, and it should be reported in combination with data from the Hematology and Thrissur. And the presence of hypergranular, agranular platelets should be reported only with thrombocytopenia. And the authors further stated that the presence of dysplastic platelets should be solely used in cases of thrombocytopenia with platelet count less than 1 lakh. And there's another group of people who have suggested that the term dysplasia should not be used for platelets and should be used restricted to nucleated red blood cells only. Now we come on to the platelet indices. Now, as we all know, platelet count can be rapidly measured using an automated analyzer. Unlike the manual count, it takes very little time. And what we have to remember is that some people do not know it, some people know it. Routine printouts from the cell counter will show most of these platelet indices. And these platelet indices are basically biomarkers of platelet activation, increase in the size, degranulation, variation in count, so many things. They are all biomarkers of platelet activation. And the measurement of platelet indices does not require additional costs and can be obtained during a routine blood count, not requiring additional blood samples. Of course, some centers actually will not report these till it's paid for, and that is also understandable. The platelet indices may have prognostic and predictive value in numerous conditions. And of these, the most important are the platelet crit, the platelet mean platelet volume, the platelet distribution width, etc. And we'll just see what are these platelet indices that are important. Now, these are the first 5 are the ones which are basically validated. What I mean by validated is that it can be taken as a diagnostic finding. It's a reportable parameter, while the others are not, technically speaking, reportable parameters. But of course, it has been validated in some of the cell counters. Some machines, they have got it, but some do not have. But the first 5 are generally, you see it in most of the cell counters. Of course, the immature platelet fraction is validated only in some counters. And now there is another one more platelet index which has come, and that is what is known as the mean platelet diameter. Now, this actually requires the scanning of blood smear to assess the actual size, the diameter of each platelet, and can be done using an Axion Carl-Zeiss scanner, but it's a very expensive procedure. And it is not validated as yet. Now, this table will tell you what is the parameter and what is the description. Mean platelet volume, it's an analyzer calculated measure of the platelet volume, and it is reported in femtoliters. Platelet distribution, volume distribution width indicates the variability, or basically the size, variability in size of the platelets. And this is reported as a percentage. Now, this is very similar to the red cell RDW, where you have the anisocytose of the red cells being reported as RDW. Then you have the platelet crit, almost the same as hematocrit. Only thing is it's very, very small, usually in the order of 0.2 to 0.25. While the RBC volume will be around 45%. And it is reported as percentage. Then you have the platelet large cell ratio. What it simply means is that it's a ratio of the large platelets to the ordinary size or the smaller platelets. And the large platelets are qualified as being greater than, volume greater than 12 femtoliters. And this is expressed as a percentage. Then you have the controversial immature platelet fraction. It's a percentage of immature platelets. And what are immature platelets? Immature platelets are reticulated platelets, platelets which contain a larger amount of RNA than the conventional normal platelets. And this is also expressed as a percentage. I will just show you some of the normal values. The mean platelet volume is approximately 7 to 11, and it's ideally it should be 8. The lower value will be around 8, but the range is like this. The PDW is usually between 8.3 to 56.6%. The ideal normal value is around 25 to 35. The platelets large cell ratio is usually 15 to 35%. The ideal value would be around 20. The PCT, there is no ideal value. This is the usual normal value. It's slightly more than this. And the immature platelet fraction, normally you find around for 3.4%. The range is 1.1 to 6.1%. Below 3% is not a good thing. And composite platelet index is no longer, it's not validated. It is basically, what happens is that the total platelet count in lakhs is multiplied by the mean platelet volume. And this is supposedly, it will give you the total platelet volume. And this is directly proportional to the risk of bleeding. For example, if it's very high or above normal range, there is very low risk of bleeding. So that's one of the points that, but this is not validated yet. Only a few papers have come out based on this. Immature platelet fraction, though controversial, it is very important because it is high in recovering dengue patients and in patients with ITP who are actually resolving, and in patients with recovering bone marrow after, it indicates bone marrow recovery after chemotherapy. While lower value means bad news for dengue patients and rarely indicates that the marrow is ineffective. Now we'll go one by one. The mean platelet value is the most commonly investigated platelet parameter and signifies the average size of the platelets. It's typically between 7, we already mentioned that. MPV over 30 is generally a feature which you see when there is peripheral platelet destruction. And this is very commonly seen in ITP, in conditions like dengue, etc. And in a patient with the condition that we are talking about, an MPV lower than 8 is not a good thing, because it's a sign of platelet hyperproduction. So if you have platelet hyperproduction in patients with dengue, it's not a good news. Of course, PDW. There is a marker of platelet anisocytosis, and it is not a very significant marker, but it will tell you the degree of platelet anisocytosis. It's very non-specific. And PDW is very high in myeloproliferative disorders, and it's very evident in the peripheral blood smear also. Platelet large cell ratio is similar to the MPV in a way that you are looking at the amount of large cells. And it's very important that in a patient with thrombocytopenia, large platelets are good, because they indicate that the bone marrow, if it has been defective or it's depressed or suppressed, it's actually recovering. Platelet crit means the actual amount of platelets. And platelet counts have little role in determining the need for transfusion in dengue. Now, this is one of the most debated area where they say, some people say that it has to be given, some people say it's not. But there is a very large group of people, school of thought, that it is the low platelet count is not by itself a reason for transfusion. So, because it can be counterproductive. That is what they have said. The term IPF is this is very immunology, like young platelets or stress platelets. Now, the reason why this immature platelet fraction, the term immature is not appropriate is because when you look at an immature cell, we expect that cell to be functionally less active than a mature platelet, mature cell. However, in case of platelets, the so-called immature platelets have a larger amount of RNA in it, which is why it's blue in color, and they are much more active than the conventional platelets. For that reason, the term immature is not appropriate. That is the present school of thought, and they call it young platelets or stress platelets. And increase in, I will continue with the use of IPF because this is what I've committed on now. The increased IPF is suggestive of a responsive marrow. This is very important. A high IPF indicates consumptive or recurring thrombocytopenic disorders. This is another key factor, and such as immune thrombocytopenic purpura. And that's a very important aspect which you have to, and also in other conditions like dengue. Now the cutoff value, what they say, this is a study by Suman from India. A cutoff value of 10.6% or more indicated that there's a 100% chance of platelet recovery by at least 20,000 platelets within the next 48 hours, and hence the transfusion decision could be put on hold. Now, a large number of studies have mentioned this. The only problem is the terminology that is used for these large platelets, and we can use whatever terminology you want. What's in a name, sort of. That sort of attitude is best in this situation. Whatever be the terminology, an increase in the so-called IPF, they are large platelets with bluish reticulated morphology, is suggestive of a responsive marrow, and platelet transfusions could possibly be put on hold. Now, this is one of the important things that have come out. Now, these are the pictures of the platelets, the so-called immature platelets, where they are blue in color, and you can see that they're blue because they have a larger amount of RNA. Now, please do remember one point which I did not mention. This immature platelet fraction can only be recognized, or these immature or young platelets or stress platelets can only be recognized in a 6-part or a 7-part cell counter. So you can't get it in the conventional 3-part and 5-part counters. Now, the composite platelet index is not a validated index. However, it's a conceptual index derived by multiplying the platelet count as a decimal with the mean platelet volume. That is, if it's in 1.5 lakhs, you multiply 1.5 into the volume, mean platelet volume. This actually theoretically gives you the actual volume of the platelet, bulk of the platelet in that sample. For example, what are we, and this is a numerical. And the greater this is, the higher the lesser the chances of logically the lesser the chances of bleeding. So this has been actually, several studies have been done in the context of dengue fever, but not so with other conditions. Now, if you see platelet crit, platelet distribution width, platelet large cell ratio in dengue, PCT is directly related to platelet counts, whereas PCLR is inversely related to platelet count, and an increased PLCR is seen in destructive thrombocytopenia. So in a situation where dengue is endemic, this can be considered to be a marker of dengue. And this is a study showing that, substantiating this same thing. Now, in summary, the use of automation for easy access of platelet indices in a complete blood count. The platelet indices are subject to a large number of papers and work investigations because of the role of platelets in hemostasis, inflammation, defense against pathogens, wound healing, and angiogenesis. So platelets is actually a jack of all trades, and particularly so that regarding wound healing, one point we have to mention is that wound healing, when healing is not proper, platelet plasma is actually given and locally. There are several studies showing that. What is more, changes in the platelet indices have been confirmed as having significant prognostic and diagnostic value in multiple diseases which have thrombocytopenia as a integral feature, that is sepsis, myocardial ischemia, trauma, and infections. More importantly, dengue fever. Thank you.